Hey everyone, and welcome to this explainer. Today, we're totally shifting how you look at a cancer diagnosis. We're going to unpack the absolute crucial difference between low-risk and high-risk skin cancer, what those labels actually mean in the real world, and why fully understanding them is honestly the most important step in your healthcare journey.
But real quick, before we get into the mechanics of risk, let's establish our foundation. The evidence we're discussing today is current as of July 11, 2026. This was reviewed by Dr. Thomas Hocker of SkinTrust.com, who is a triple board-certified dermatologist, Mohs surgeon, and dermatopathologist, as well as an author and educator. All right, let's jump right into it.
Consider this for a second. Why do two patients with the exact same skin cancer diagnosis need completely different treatments? Think about it. If you and a friend both find out you have a basal cell carcinoma, you'd probably expect the exact same medical plan, right? Well, that's actually a massive misconception. The name of the diagnosis by itself simply isn't enough information. The truth is, the cancer name, whether it's basal cell or squamous cell, is really only the starting point. It's kind of like knowing the title of a book, but not the actual story. Your complete treatment plan is dictated by the risk factors. We're talking about things like the tumor's location, its size, the borders, how deep it goes, and whether it's recurred before. Those specific, highly individualized features dictate whether you just need a straightforward office treatment or if you're looking at complex specialist surgery. A really great mental model for understanding this is what we call the risk stack. You see, risk isn't just one big, scary word. It's actually a specific combination of 5 clinical factors stacked together. First up is the tumor itself, its size and its growth rate. Second is pathology, so what's happening microscopically. Third is location, the actual anatomy involved on your body. Fourth is the patient, meaning your immune status and overall health. And fifth is history, things like prior treatments or existing scarring. When your doctor talks about your risk, they're actually analyzing this precise 5-part stack.
Let's clarify what these labels actually mean in practice, because honestly, the words alone can be pretty misleading. Low risk absolutely does not mean harmless. You still have to treat it. It simply means a simpler treatment is highly likely to work. On the flip side, high risk does not mean hopeless. Not at all. It just means the cancer is more likely to recur or extend invisibly under the skin, so the medical follow-up needs to be much more deliberate. Think of it as an instruction manual for your doctor rather than some kind of crystal ball for your future.
Now, when you read your actual pathology reports, you're probably going to run into some heavy medical jargon, so let's translate that. You'll often see terms like grade or differentiation. This answers a very specific question. How abnormal do the tumor cells actually look under a microscope? Poor differentiation means the cells look highly abnormal and aggressive, which adds a pretty heavy block to that risk stack we just talked about.
So how does that contrast with the word stage? While grade is all about what the cells look like, stage answers a completely different question. How far has the cancer actually progressed? Basically, has it packed its bags and moved into the lymph nodes or other organs? Grade guides your local treatment right there on the skin, but staging evaluates the geographic spread. They definitely overlap, but they are entirely different metrics.
Let's break down the first part of our risk stack, tumor behavior and history. What actually raises your risk level? Fast growth, large size, and blurry clinical borders all play a part. But a huge flashing red flag is recurrence. If a tumor has returned after a previous treatment, the risk level skyrockets. Why? Because scar tissue from that first treatment acts like camouflage. It hides the edges of the tumor, making it so much harder to completely clear it the second time around.
Location matters immensely too. High-risk anatomy includes places like the eyelid, nose, lip, ear, hands, feet, and genitals. And I want to be clear, this isn't just about cosmetic vanity. High-risk sites are dangerous for deeply practical reasons. It's just harder to see tumor extensions against complex skin in these areas. Plus, a recurrence threatens absolutely crucial functions, like your ability to see, or hear, or eat. And on top of that, taking an unnecessarily wide surgical margin just to be safe makes reconstruction in these delicate areas much harder.
But we can't just look at the tumor in a vacuum. We also have to look at the patient themselves, and this dynamic swings in 2 completely different directions. On one hand, immune suppression, say from an organ transplant or certain medications, can alter the biology of the cancer, making it way more aggressive and raising the risk. But on the other hand, we have to consider severe frailty. If a patient has a highly limited life expectancy, the decision might swing entirely the other way, where observation actually becomes the most logical, compassionate path. The treatment always has to fit the patient, not just the tumor.
So, how do specific cancers use this framework in the real world?
Let's take basal cell carcinoma, or BCC. For BCC, risk classification mainly guides how we treat the local area. While BCC rarely spreads to distant organs, we absolutely can't underestimate it. A low-risk nodular BCC on your back is handled very differently from a high-risk infiltrative BCC on your nose. The main danger with a high-risk BCC is local destruction of tissue, which is a very real threat that requires careful targeted management.
Now, squamous cell carcinoma, or CSCC, brings a noticeably more serious framework to the table. Unlike BCC, CSCC carries a real risk of spreading to the lymph nodes and causing disease-specific death. Current guidelines actually separate CSCC into low, high, and very high risk categories using some incredibly strict thresholds. If a tumor is over 2 centimeters, or it's deeper than 6 millimeters, or if it has invaded a nerve, that moves you rapidly up that risk ladder.
To ground this in some objective reality, let's look at a major cohort study of over 10,000 CSCC tumors. It proves that these risk labels aren't just decorative wording. For low-risk tumors, the adjusted 5-year local recurrence rate was a tiny 0.8%. But for very high-risk tumors, that number jumped to 9.4%. Even more sobering, disease-specific death leapt from just 0.1% for low risk all the way to 10.5% for very high-risk tumors. This is exactly why identifying these risk factors accurately from day one is so paramount.
So when the risk goes up, what do we actually do about it? Well, in that exact same 10,000 tumor study, using Mohs surgery, which is complete mapped margin assessment, was associated with a 35% lower subhazard of local recurrence compared to just a standard wide local excision. It was also associated with a 62% lower subhazard of distant metastases and a 45% lower subhazard of disease-specific death. The way the surgeon maps and checks the microscopic edges of the tissue matters exponentially more when you're dealing with high-risk tumors. Before we go any further, I want to make this explicitly clear. If the diagnosis is melanoma or a rare tumor like Merkel cell carcinoma, everything we just discussed about those BCC and CSCC tables goes completely out the window. They use a totally different rulebook. Melanoma relies on its own unique staging system, based on things like Breslow thickness and microscopic ulceration. You absolutely must route directly to melanoma-specific guidance for those diagnoses.
Okay, so if you do happen to have a high-risk BCC or CSCC, what practically changes in your day-to-day care? A few key things. First, you're looking at specialist involvement, like bringing in a fellowship-trained Mohs surgeon or a multidisciplinary team. Mapped margin assessment becomes the gold standard to ensure all those invisible edges are completely clear. You might also have discussions about imaging or staging, and you will absolutely need a much closer, more rigorous follow-up schedule. It's a deliberate, upgraded plan.
But there is a delicate balance we have to strike here. Just as we don't want to underestimate a high-risk tumor with a simple topical treatment, we also really don't want to overtreat a low-risk one. A genuinely low-risk, small, superficial tumor on the shoulder should not automatically get the most complex intensive surgery. A standard excision or even just scraping might be perfectly appropriate. The low-risk label is the gate that allows simpler, less invasive treatments to be highly effective and totally appropriate.
Which brings us to a really fascinating question. When might skin cancer surgery actually be unnecessary? Now, I know wait and see isn't exactly a popular slogan in cancer care, but in very specific circumstances, choosing not to operate is actually an evidence-based medical strategy, rather than just neglect. It requires incredibly careful physician guidance, but there are clear moments when it applies. Let's anchor this observation strategy with some data. In one observational study looking at 280 basal cell carcinomas in predominantly elderly patients with a median age of 83, the doctors chose a watchful waiting approach. During follow-up, only 46.8% of those observed tumors actually grew. For frail patients, or folks with major comorbidities and a limited life expectancy, the physical burden of surgery might simply exceed any actual benefit. In those select cases, observation isn't giving up. It's a completely valid, medically sound choice.
So how do you take all of this and advocate for yourself? Take these exact questions directly to your dermatologist. Ask them, which specific microscopic features make this tumor low or high risk? Does the location on my body change our plan? And importantly, would mapped margins like Mohs surgery improve my outcome? By asking these questions, you're stepping into a shared decision-making process that's based on your unique risk stack. As we wrap up this explainer, let's establish some actionable next steps. Use the concepts we've covered today as your personal routing guide.
From here, you should move on to read the specific treatment pages for your exact diagnosis, whether that's BCC, CSC, or melanoma. And if you know you have a high-risk feature, be sure to review specific resources like Do I Need Mohs Surgery to clearly understand if mapped margin assessment should be a core part of your plan.
I want to leave you with this final thought. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. The next time you look at a pathology report, I want you to remember that 5-part risk stack. Don't settle for just knowing the name of the cancer. Ask about the risk features, advocate for your unique profile, and use this new mental model to make absolutely sure you receive your optimal care. Thanks so much for joining me today, and keep learning.